Hello everyone and a warm welcome to this webinar. So we are MedGenome. We are the leaders in genetic testing in India. And today's webinar is a very special one. We have the privilege of hosting a very distinguished speaker who will be presenting to you about a topic that is at the cutting edge of genetic research. And it has the potential to change the way preventive healthcare is practiced. The topic is genome-wide polygenic score in coronary artery disease, clinical utility and impact. And our speaker is Dr. Amit Khera, cardiologist at Massachusetts General Hospital and assistant professor at Harvard Medical School. In addition to our distinguished speaker, we also have a very distinguished panel of eminent cardiologists with us. That is Dr. H.K. Chopra and Dr. Rakesh Gupta, who will be presiding over this webinar. So before we start off with our main speaker, I'd like to call upon our eminent panelists to give their opening remarks. So I now call upon Dr. Chopra. So to introduce Dr. Chopra, Dr. Chopra is a cardiologist with over 30 years of clinical experience. He has played a key role in advancing many clinical modalities like thrombolytic color Doppler echocardiogram. He has treated current and former presidents and vice presidents of India. He has multiple awards to his credit, such as Icon of Century in Clinical Cardiology and Echocardiography, presented to him by Bharat Ratna Dr. APJ Abdul Kalam, former President of India in 2008. He was conferred with International Award for Excellence in Cardiology by the American Association of Cardiologists of Indian origin in 2016. And he's been the multiple recipient of other awards too, including first Indian cardiologist to be the founder chairman of the World Heart Academy, launched in 2006. He has over 684 publications in various national and international journals of cardiology. He's also the former editor-in-chief of multiple cardiology journals and has conducted over 2,000 cardiology public health workshops. So it is our privilege to welcome Dr. Chopra. Dr. Chopra, if you could please give your opening remarks, sir.
Thank you very much, sir. I think it's a real pleasure and honor indeed for me to be here and sharing a very prestigious webinar organized by MedGenome. And you just heard the title of the webinar, Genome-wide Polygenic Score in Coronary Artery Disease, Clinical Utility and its Impact. I personally feel it has a huge potential, huge power, and huge prowess in the clinical practice. And it will have a huge potential in the preventive cardiology to predict coronary artery disease early so that the timely intervention can be undertaken, and it may help us in reducing the morbidity and mortality which is CAD inflicted, especially in the young patients in India. As we all know, that India is the world capital of hypertension, coronary artery disease, diabetes mellitus, obesity, metabolic syndrome, and whatnot. We really feel that we have a very eminent speaker with us, Amit Vora. I write from the Massachusetts General Hospital, and he's also the assistant professor of Harvard Medical School, and his tremendous contribution. I've already gone through the website and I've gone through the details of what his work is. And I'm very happy, along with me, Dr. Rakesh Gupta, who is the also chairperson with me. I'll request Rakesh Gupta to say a few words before we start the proceeding of this meeting. Rakesh.
Dr. Rakesh Gupta is the director of cardiologist of Doppler Center, GROP, Institute of Cardiology. He has done his postgraduate in SN Medical College, Agra, and in 1986 with fellowship in cardiology from Thomas Jefferson University Hospital, Philadelphia in the USA. He is the past president of Cardiology Society of India. He is the past associate editor of Indian Heart Journal of CSI, past editor-in-chief of Journal of Indian Academy of Echocardiography, and he's also the past president of Indian Academy of he's the governing council member of Indian College of Physicians of API. So I'd request Dr. Gupta to give us his talks.
Thank you very much, Mr. Joseph, for inviting me to chair this session. Well, India is on the verge of having a CAD blast. That's what the exact word is. Right from the age of 10 to 15 years of age and up to the age of 70, many people are suffering knowingly and unknowingly with the coronary artery disease. Many factors which can really diagnose coronary artery disease are available. They are in pipeline. And I'm sure this genome modality, which is trying to predict a coronary artery disease, is going to be very exciting over a period of time. We in India, we as a cardiologist, we as a general population, we need something to let us understand how we can attract or how we can diagnose at a much earlier age so that we can attack them right in the beginning itself. So that full-fledged acute coronary syndromes do not happen and we can prevent our population from the onslaught of this coronary artery disease. I'm sure Dr. Amit Khera, who is a renowned person working on this particular modality from USA in Massachusetts General Hospital, who has spent a lot of work on this particular modality, is going to make a lot of difference. And that's what we are eagerly waiting to listen from him. And I'll request Dr. Amit and Mr. Joseph to introduce Dr. Amit Khera so that he starts his presentation. Thank you very much and look forward to this kind of a presentation.
Okay, so thank you very much, Dr. Gupta, for those words. So now we move on to the main speaker. So we have Dr. Amit Khera with us. He's a very distinguished cardiologist working at the Massachusetts General Hospital and also assistant professor at Harvard Medical School. He received his MD with Alpha Omega Alpha distinction from Perelman School of Medicine at the University of Pennsylvania. He completed a master's in science at Harvard School of Public Health and postdoctoral research fellow at, with Dr. Shekhar Kadiresan in human genetics at the Boston Institute of Broad Institute, MIT, and Harvard. He has developed expertise in epidemiology, clinical medicine, and human genetics. Among his scientific contributions, he pioneered the use of a new approach to quantify genetic risk, genome-wide polygenic risk code for common diseases, and develop biomarkers that provide new biological insights, analyze large-scale gene editing data to highlight key pathways driving risk for cardiometabolic diseases. Dr. Khera has authored more than 75 scientific publications, including lead authored publications in New England Journal of Medicine, Journal of American Medical Association, Cell, Nature Reviews, Genetics, Nature Genetics, Journal of American College of Cardiology and Circulation. He is also the recipient of the 2017 National Lipid Association Junior Faculty Award and the 2019 recipient of Douglas P. Zipes Distinguished Young Scientist Award for American College of Cardiology. So without further delay, I now request Dr. Khera to take this webinar forward. So over to you, Dr. Khera.
Hello and good afternoon. My name is Amit Khera. I'm a cardiologist by training, and I started a new preventive genomics clinic at my hospital. And in the remainder of my time, I actually lead a research group really focused on human genetics and how can human genetics help us understand disease biology and how can human genetics actually enhance clinical care. And so today, my title of my talk is Genome-wide Polygenic Scores for Coronary Artery Disease. So as background, South Asians, including folks living in India, we suffer from coronary artery disease at much higher rates from other ethnicities. Here's an analysis we recently did in the United Kingdom, and we studied 8,000 individuals followed for over 13 years. And the x-axis is time, and on the y-axis is the chance of having a heart attack. And what you can see is that we actually have a more than double the risk of heart attack compared to people with European ancestry. Now, we're not only at higher risk, but this increased risk is actually not captured by current clinical risk estimators. In the United States, we typically use the pooled cohort equations to predict 10-year risk of heart attack or stroke. And here, what you're seeing is that the predicted risk is actually identical between South Asians and European individuals. So we're at much higher risk, but that risk is not captured currently by clinical risk estimators. And in the United States, actually, we can consider South Asian ancestry a risk enhancer, meaning some acknowledgement that we actually suffer at much higher rates. So might genetics play a role? And here, what's interesting to think about is how might DNA predispose someone to coronary artery disease or heart attack? And the traditional approach is really to think about what we call monogenic risk mutations. So these are single base pair changes, so change in just one spot in your DNA that in and of themselves can have a very large effect. And typically that triples or quadruples your risk by disrupting a very specific pathway. Here, the classic example is familial hypercholesterolemia. You cannot clear cholesterol from your circulation, have very high cholesterol from the time you're born, and this triples or quadruples your risk. But more recently, we've thought about what about everybody else? And here, we propose a polygenic model. So poly means many, and in a polygenic model, it's not one mutation, but actually many different variants, each of which has a small effect, changes your risk by 1 or 2%. And it's actually many different pathways. But you can imagine that just by chance, some people will have inherited just unlucky and more of the risk variants. And in aggregate, the impact on disease could be more substantial. This website actually will give some background, polygenicscores.org/explained, on what a polygenic score is. And I encourage you to look at it after the talk. So recently we set out to do an experiment, which is to say, how might we interpret someone's risk for myocardial infarction or coronary disease, a young patient coming to the hospital with a heart attack at a young age? And to do this, we designed actually a multi-ethnic study, 2,000 people who came to a US hospital with a heart attack at age less than 55, and 4,000 controls. And these were also in the United States, people who remained free of cardiovascular disease. And we did whole genome sequencing in all of them. And what you can see is that we first looked for these monogenic familial hypercholesterolemia mutations. And it turns out that we were able to find one of these mutations in about 2% of the cases. So 2% of people coming to a US hospital with a heart attack at a young age actually have one of these monogenic mutations. Now, on average, these mutations lead to about a 3.8-fold, about a quadrupling of their risk. Now, here I'm showing you on the y-axis is their LDL cholesterol, their bad cholesterol levels. And on the x-axis is stratified by whether or not they had one of these mutations. And it turns out that although there's some overlap, the people who had a mutation had significantly higher LDL cholesterol, as we would expect. Average is 202 versus 124 milligrams per deciliter. So what this means is that although it's not perfect, LDL cholesterol is a reasonable proxy or surrogate for the presence of one of these mutations. We then said, okay, well, can we actually identify additional high-risk individuals, this time using a polygenic risk model? In order to do this, we needed a genome-wide polygenic score. So how did we actually make one? First, we actually compared the DNA at over 6.6 million spots, where my DNA might differ from yours, in 60,000 people who had had a heart attack and 120,000 controls. This is called the Genome-wide Association study. At the end of the study, you end up with a list of 6 million rows, and each variant, does it change risk by 1%, decrease risk by 2%, and so forth. So if a variant is more common in the people who had a heart attack, those are called risk variants. And if they're more common in the people that didn't, those are protective variants. And we actually use several computational algorithms to combine information from all of these variants into a single number. Now, we then said, how are we going to choose which score actually does the best? And here we studied 120,000 individuals from the United Kingdom Biobank. And we said, okay, which is the best score at picking who are 4,000 people who had disease versus 120,000 people who didn't? And what we realized is that the score that integrated information from all 6.6 million variants, figuring out how to weight them, actually performed the best at discriminating the risk. So we said, okay, this is our new score. Let's go out and test that score in other data sets. So we first tested it in over 300,000 additional people from the United Kingdom Biobank. Here I'm showing you the distribution of the score, and it's actually normally distributed in the population. Some people high, some people low, just like cholesterol or blood pressure. We then said, okay, well, how does that variation actually contribute to risk? And this is only in the European ancestry individuals of the UK Biobank. So here I'm showing you 100 dots. Each dot represents 3,000 people. On the x-axis is people just binned into the percentile of their polygenic score. And on the y-axis is the chance that they had developed coronary artery disease by the time they had reached middle age, 55 or so. And what you can see is that this measure, available from the time of birth, actually predicts very strongly your chance of having developed coronary disease. It was less than 1% if you were in the lowest percentile, and over 11% if you were in the highest percentile. So, but the traditional approach actually is to think about carriers versus non-carriers of these mutations. So we said, what if we arbitrarily say that the top 5% of the score distribution is actually a carrier of a high polygenic score, and the bottom 95% is actually a non-carrier? And what was really surprising to us and what was really striking is that the top 5% of the score distribution actually had greater than triple the normal risk for coronary disease. So they actually had risk that was equivalent to a monogenic familial hypercholesterolemia mutation. We then said, okay, let's come back to the patients who came to the hospital in the United States. And we said, okay, 2% have a monogenic mutation we know. How many of them actually have a high polygenic score, which is the top 5% of the distribution? And here what we observed is that it was not 1.7%, but actually 17%, so 10 times as many people who actually had a very high polygenic score. And despite being much more common, the risk conferred was actually almost identical, 3.7-fold increase. Now, here I'm showing you on the y-axis the folks' LDL cholesterol, and on the x-axis stratification by the high polygenic score, yes or no. And what you can see is that these individuals actually cannot be distinguished by a high LDL cholesterol. The values are a little bit higher, as you might predict, because LDL is an inherited and causal risk factor for coronary artery disease, but you can never pick these individuals out of a crowd based on LDL cholesterol. Now, it turns out actually that it's not just LDL cholesterol, but actually any traditional risk factor, they're all inadequate to pinpoint these very high polygenic score individuals. Family history, 44% versus 35%. Hypertension, 32% versus 28%. So although all the traditional risk factors are slightly elevated, none are enough to be useful for if 20 patients come into my clinic, can I actually pick out the one with the highest polygenic score? So why is it that these traditional risk factors are inadequate to identify these very high risk individuals? Well, if you look at the variants, the genetic variants that are most strongly contributing to the score, it turns out that about 25% of them are actually associated with cholesterol and triglycerides and lipoprotein a. And an additional 20 or 30% are actually associated with things that we know are important, but actually we don't measure in routine clinical practice: inflammation, cellular proliferation, vascular remodeling, vascular tone. And these are things that we don't capture in routine clinical practice. And the remaining 50% of the variants, actually, we aren't sure what their mechanism is, and the pathway actually remains uncertain. So there's some important work to be done to understand new pathways, but this, taken together, really does explain why the traditional risk factors don't pinpoint these high polygenic score individuals. So if you have a high polygenic score, is DNA destiny? Meaning, are you predetermined to go on to have a heart attack at a young age? And this is something that many patients are quite concerned about. And we looked at a couple of years ago in a paper in the New England Journal of Medicine, really to what extent can a healthy lifestyle actually offset high polygenic score? So we did something very simple. We defined a healthy lifestyle based on American Heart Association criteria: 4 key risk factors: no smoking, maintaining a normal weight, exercising regularly, and having a healthy diet. And we said if you have at least 3 of these factors, you have a favorable lifestyle, 2 intermediate, and 0 to 1, you actually have an unfavorable lifestyle. We then identified over 50,000 individuals and followed them forward in time for a very long period of time. Here I'm showing you on the y-axis is the chance of coronary artery disease events over 10 years. And on the x-axis, I'm showing you just those with a high polygenic score. So each of these bars had the same high polygenic score. But what you can see is that if you had an unfavorable lifestyle, your chance of developing disease was about 11%. If you had a favorable lifestyle, it was only about 5%. So you had about a 50% lower event rate for those who adhered to a healthy lifestyle. And it turns out that if you had bad genes but a good lifestyle, you actually were able to return your risk to the population average. You could never do as well as someone with a good polygenic score and good lifestyle, but you were able to fully offset your inherited risk and get to the population average. So the summary here is that the genome-wide polygenic score actually identifies 10 times as many individuals as compared to monogenic mutations. So for monogenic, about 1.7% of people with a heart attack have one. It associated with about a quadrupling of your risk. In current clinical practice, we don't do genetic testing that often. I think we should, but at the moment it's identified by very high LDL cholesterol. And we know that if we find these people, we can offer them a number of interventions, statins, ezetimibe, and PCSK9 inhibitors to really lower their cholesterol and decrease their risk. By contrast, a high polygenic score is common in about 17% of people with a heart attack. It contributes the same quadrupling of the risk. These individuals are totally undiagnosed and flying under the radar within our clinical practice currently, despite the fact that we know that both lifestyle and medications can really offset that risk. So what about future risk, and how does polygenic score actually compare to traditional risk in predicting if someone's future risk of developing coronary artery disease? And here, we recently did analysis again in the UK Biobank, 300,000 people, mostly European ancestry and not South Asian, but they are followed for about 8 years. 7,000 of them went on to develop coronary artery disease. And here I'm showing you in this histogram, the people who had a coronary artery disease event in red and everybody else in blue. And what you can see is that there's an overlap in the distributions, but the curve is shifted for those who had an event. And one measure of that is actually the area under the curve, or C statistic. It turns out the polygenic score alone has an AUC of about 0.61. So what does that actually mean? Well, I think it's helpful to actually put that into context with other traditional risk factors that we measure in clinical practice. And here what you can see is that the curves are similarly overlapping for LDL cholesterol. And it turns out that the AUC, which is a marker of how good a predictor it is actually higher for polygenic score than for LDL cholesterol. So it's a better risk predictor than LDL cholesterol, but it's available from the time of birth. And what was really impressive is that it wasn't just LDL cholesterol, but the AUC was higher than actually for any of the traditional risk factors. So here I'm showing you that we use in the United States these pooled cohort equations. And I'm showing you on the x-axis, people binned into our current category. So low is less than a 5% chance of having a heart attack over 10 years. High is 20%, and others are in between. And on the y-axis is the 10-year chance that they actually developed a coronary artery event. And this again was the UK Biobank. And what you can see is really striking gradient. So even if you had the same predicted clinical risk, if you had a low polygenic score, for example, in the intermediate group, your risk was about 2.8%, versus if you had a high polygenic score, it was actually 8%. So really a strong gradient within each stratum of the polygenic score. Now, here I'm showing you that we replicated this result in the Malmo diet and cancer study. This was a study performed in Sweden, and we showed an almost identical result. So regardless of what your clinical risk says, if you have a high polygenic score versus a low polygenic score, your actual risk is very different. So how do we put this all together? And I talked about monogenic mutations and polygenic scores. But one of the things we observed in our clinical practice is that even for those with a very high monogenic risk mutation, familial hypercholesterolemia mutation, many of those actually do not go on to develop heart disease. And we call that incomplete penetrance, meaning you have high risk mutation, monogenic mutation, but don't develop disease. And from a conceptual standpoint, let's return to our idea of how might DNA predispose to coronary artery disease. Monogenic, single mutation, one pathway. Polygenic, many variants, many pathways. So it's not obvious how these would come together. But the traditional approach, again, is to look at just one base pair. But we asked the question, what about the remaining 3 billion base pairs in the genome? Might they actually also be important? And so we started with studying 13,000 people, about half of which had coronary artery disease. And we first showed that those who had a familial hypercholesterolemia mutation, consistent with many previous studies, actually had about a tripling of their risk for coronary artery disease, an odds ratio of 3.2, consistent with many previous studies. Now, what if we now bring in the polygenic score? And here on the x-axis, I'm showing you people binned by their polygenic score. And what you can see is that if you had a monogenic mutation, but a low polygenic score, your odds ratio is only 1.3. So your odds ratio is actually comparable to the population average. By contrast, if you had a monogenic mutation and a high polygenic score, this is what we call a genetic double whammy, meaning you had very high risk, about 13-fold increased risk from the time you were born. So we then went on to generalize this to about 50,000 people in the UK Biobank. And again, the traditional approach is really to say monogenic mutation equals high risk. So here I'm showing you the y-axis now is just the chance that you develop coronary artery disease by age 75 years. And we said that if you have a monogenic mutation, on average, that chance is about 40%, versus if you didn't, you're about 13%. So again, about a threefold increased risk. And that's how we practice clinical medicine now. But in the new approach, what we realize now is the polygenic background is actually very important. And so now I'm showing you again, the x-axis is the percentile of the polygenic score, and the y-axis is the chance that you developed heart disease over the 75 years. And what you can see is a really striking gradient. So look at the dots in blue. These are people who have a familial hypercholesterolemia mutation. If you have a very low polygenic score, your risk is only about 18%, versus if you have a high polygenic score, your risk is 80%. So it's about a fourfold gradient in risk if we're able to take into account the polygenic background as well. So I think that recognition of this high inherited risk is a very important public health opportunity. And really the question is, if you knew, we can now put you in one of these 200 dots from the time you're born. And if you knew, what would you actually do? And as I mentioned, this is very actionable, especially if you find out early in life. We know, as I mentioned, that adherence to a healthy lifestyle can reduce your risk by about 50%. And we've done previous studies which actually show that statins, cholesterol-lowering medicines, and even PCSK9 inhibitors have also been shown to have their most impact in those with a high polygenic score, about a 40 to 50% risk reduction. So again, we have at least 2 interventions to mitigate risk if we're able to find these individuals before they have their event. So we are very excited, at least in the United States this year, and over the next month or so, we actually are planning to launch a new clinical test because we think state-of-the-art genome interpretation for heart disease is actually looking at both monogenic and polygenic. If you have a no monogenic mutation and a low polygenic score, we think your risk of developing heart disease is only about 4%, versus if you have this double whammy, monogenic and high PRS, we think the risk is about 78%, and that this can be determined from the time of birth. And so this is a test initially just being offered at our hospital, Massachusetts General Hospital, and with a collaborator in the US called Color Genomics. So again, when we think about how genetics plays an important role, we're really talking about genome interpretation, looking at someone's DNA, identifying high inherited risk, and able to then help them. And so this is really the whole idea behind genomic medicine. Really identify high-risk individuals, disclose that they're actually at high risk, and then ultimately, this is the hardest part, but we want to show that we can intervene to actually decrease their risk for disease. We want to help them overcome any inherited risk that's identified. So in order to do this, we actually think that we needed a new clinical infrastructure at our hospital. And so we actually launched a new preventive genomics clinic last year. We put together a team of doctors, genetic counselors, geneticists, and other folks, really with an aim of using genetic information to better understand, predict, and prevent disease. And we embedded this within our primary care practice because that's where I think genomic medicine, the future of genomic medicine actually is, both in the United States and India eventually. We actually are trying to educate our primary care providers along the way. And we're going to make all of our educational tools actually open source. So anybody around the world can take advantage of it. So one example actually is what we call an e-consult, electronic consulting. So anybody in our electronic medical record, any doctor in our system, can ask a question about their patient related to genetics. And when they ask that question, our genetic counselor and our doctors actually go through and review the patient's medical record to make recommendations. Oh, this person may need a genetic test. This other genetic test maybe is not that important. And in some cases, we recommend they actually just come in for a clinic appointment. So what do we actually do in this clinic? Well, one important part is to actually guide asymptomatic individuals who have a pathogenic variant like that related to familial hypercholesterolemia. So we actually have a biobank of people who have volunteered to be at our hospital. We're finding everybody who has a familial hypercholesterolemia mutation, and we're inviting them to come into our clinical practice to get care. Second, we want to discuss genetic testing for those who have symptoms or a family history. Which genetic test is most appropriate? Should you get a monogenic or polygenic or both test? And what might you expect from the results of this test to show? And so that's really an important role of really discussing with the patient the value of genetic testing. And lastly, we want to be able to provide state-of-the-art genome interpretation for those who are just curious or concerned. And in that case, often in the US, that's not covered by health insurance plans currently, but can be offered at a cost of around $250 or so. So this was work that was focused mostly on individuals of European ancestry. And we set out in collaboration with MedGenome and a Genome Asia project last year to really say, how did this actually work in South Asian populations and in India? And it turns out nobody had ever studied that before. And the reason that question is quite important is that South Asians are about almost 2 billion people. So it's 23% of the global population. But here I'm showing you on the x-axis is time, and on the y-axis is the proportion of individuals who are present in the genome-wide association studies, the genetic studies to date. And what you can see is that the blue area is European ancestry. That's actually about 70 to 80% of the data. And there's a tiny sliver, the red, is South Asians. And it turns out that actually only 1.3% of all genetic association studies to date represent data from South Asian individuals. And out of all the ancestral groups, East Asian, African, Hispanic, and Latino, South Asians are actually the most underrepresented. And because we have less data, this underrepresentation actually translates into lower predictive accuracy across many diseases. So here I'm showing you on the y-axis is just the prediction accuracy, and that you can see that the South Asians, seen here in green, actually compared to Europeans, it's across many diseases, it's only about 60 to 70% is accurate. So we thought it was important to actually set out to revisit this question. And so to do this, we actually built a very focused effort to derive and validate a polygenic score specifically within South Asian populations. So to do this, we took association statistics, like I mentioned, from a previous genome-wide association study. So 6.6 million variants. We studied how those variants are inherited together. That's called our linkage disequilibrium reference panel. And we actually derived several candidate scores using state-of-the-art algorithms. We then said, okay, well, how does this polygenic score actually perform? This is validation in 7,000 or 8,000 individuals in the United Kingdom Biobank. And then we tested the score, in this case, in a BRAVE study, which was actually a Bangladeshi study of about 247 cases and 244 controls. And at the end of this process, we actually had a polygenic score that performed quite well, almost as well as what we observed in the European ancestry individuals, which was quite exciting and new for us. We then said, okay, well, we think this is quite important, could be a very useful tool in India, but we needed to build a clinical grade assessment for assessing polygenic score, and this was done in collaboration with MedGenome. And so here, what I'm showing you is we needed a reference population of 1,500 South Asian individuals. This came from the Genome Asia study. And this reference population is needed because first, we actually quantify people's genetic ancestry using principal components. So here, what I'm showing you is that there's principal component number 1, principal component number 2. And what you can see is that the red dots are individuals maybe from North India, the purple dots are ones from South India, and we really need to quantify someone's ancestry very precisely. And that's what this reference population is useful for. Now, it's useful for a second thing as well, which is to say, if you have a polygenic score of 10, if you have a cholesterol of 200, we know that that's very high because we've studied the cholesterol distribution in the population in many thousands of individuals. But what about a polygenic score? Is a polygenic score of 10 good? Is it bad? It turns out that unless we have a reference distribution, we really have no way of knowing. And so what we did is used this 1,500 people to actually create a reference distribution, and it's bell-shaped, as I mentioned earlier. So that's basically the foundation of our pipeline. And then we said, okay, let's imagine you have a patient, one of your patients who's coming in and wants their polygenic score. Well, first you need to calculate the polygenic score based on the 6.6 million genetic variants. We then project that individual using genetics very precisely into their quantitative genetic ancestry space called principal components. And that allows us to now calculate an ancestry adjusted polygenic score and put that on the distribution. And that's when we can really say your polygenic score is high or polygenic score is low. And we typically report it in terms of a percentile, meaning compared to other people with a similar genetic background, you have a polygenic score, for example, in the 95th percentile. So 5% of the population has a polygenic score at least as high as you, and 95% of the population actually has a polygenic score that's lower than you. So we then, in collaboration with MedGenome, actually went out and recruited 1,800 coronary artery disease patients in India and 1,163 controls. And we said, okay, well, how does the score actually perform in an Indian population? And here I'm showing you the y-axis is the percentile of the polygenic score, cases and controls. And what you can see is that there's a significant shift. So the red dots, or the red box plot, actually shows that on average, those who went on to develop heart disease have a polygenic score in the 70th or 70th percentile, versus if you were a control, you were at the population average around 50th percentile. And so how does that track with risk? Well, I'm showing you on the x-axis on the right, the quintile of the polygenic score, and the y-axis, the odds ratio for developing coronary artery disease. And what you can see is there's about a 4-fold gradient just based on genetic variation alone. And just as in the previous studies, we can't find the high polygenic score individuals based on traditional risk factors like diabetes and blood pressure and cholesterol and so forth. So really the only genetics is the only way to find these very high genetic risk individuals. So another approach, as I mentioned, is to look at high versus people with average polygenic risk. And so here I'm showing you, for example, this is again, MedGenome Indian data. The top 2.5% of the polygenic score, for example, what you can see is that they have more than triple the risk of developing heart attack from the time they're born. And if you use a less strict threshold, the top 20%, they have about a 2-fold increased risk. And so again, we're finding that there's a significant gradient across the score, and that those who have high risk in the tails of the polygenic score distribution really have very high risk that they're born with. So I want to conclude because I know there's several questions from the audience, but really what I wanted to take home points are the rise of genome interpretation for coronary artery disease provides an opportunity to really deliver on genomic medicine. South Asians in particular have been understudied by the genetics community for a variety of reasons, but we in MedGenome and Genome Asia and others are actually very committed over the next several years to building out additional Indian data sets that will enable us to further improve the predictive accuracy for Indian populations. But even already, the score performs quite well. So the polygenic scores, again, it distills your inherited risk from your DNA into a single number. And we can use this number to identify high-risk patients flying under the radar. So even when we look at our own hospital, these individuals are not being identified. They're not being brought into clinical care for the cardiologist. They're not getting statin medications and so forth. So they really are totally flying under the radar within our clinical practice. And moving forward, what our data shows is that the state-of-the-art genetic testing for coronary artery disease really does require assessment of both monogenic mutations like familial hypercholesterolemia and a polygenic score. And that's why we're so excited, at least in the United States, as a pilot, to be offering that test starting next month. And lastly, genetic testing can be performed very early in life, and the results are actionable. So if you find people among your patients who have a high polygenic score, our goal is actually to give a decades-long head start for prevention, things like lifestyle. Maybe you start a statin medication earlier and so forth. And so with that, I definitely want to thank all the organizers and you for your time and attention. I'm going to, the moderator should feel free to interrupt me. Otherwise, I'm going to start answering some of the questions that folks have put in.
Yeah, Dr. Kira, please go ahead.
So the first question is, how can the polygenic score actually be negative in the normal distribution? And here, this is just a, in order to interpret it, we actually just put it in units of a z-score. And that's just a score where is commonly used in risk prediction, where we force the average to be 0. We force half the people to be below 0, half the people to be above 0. So for example, a score of -1 means that your score is about 1 standard deviation below the population average. Turns out you're in about the 10th or 15th percentile. So that's why you might see that unlike things like blood pressure, which can never be negative, a polygenic score we allow it to be negative or positive. Now, Ashok actually asked the second question, which is, what percentage of the 6.6 million variants are actually in the coding region of the genome versus the non-coding region? And this is a very important question because it turns out if you look at all the 3 billion base pairs in the genome, it's only about 1% that are actually in the protein coding sequence, and 99% are actually in the non-coding region. So in our score, it's about that, actually 1% of the variants are in the coding region and about 99% are not. So we do know that the weights in the coding region are actually a little bit higher. On average, they tend to have a higher effect, but it's also true that the majority of the top hits are actually not in the coding region. So he asks if you allocate any particular significance to those variants, we do allow the model to put a weight on those non-coding variants, but we think that there are ways to do this even more in more sophisticated ways, where, for example, if it's in the coding region, we give the variant even more weight, and that's actually something we've shown in preliminary data that can be quite helpful. Can you actually use the variants in the coding regions to actually identify new target discovery and new therapeutics by defining protective mutations? This is a very important point. Traditionally, when we think about genetic risk, we're thinking about something bad, things that increase your risk. But it turns out actually there are many examples where the variants can actually decrease your risk. And an example is in the United States, about 2% of African Americans actually have a mutation that breaks or disrupts PCSK9, a very important gene for lipid metabolism. And these individuals, from the time they're born, actually are protected from heart attack. It's a protective mutation. And based on that observation, this was led to the development of PCSK9 inhibitors, so medications that can actually be used in everybody, and actually have been shown to dramatically decrease risk of heart disease. So this is medications I use all the time in my clinical practice. And it turns out that this is not isolated to PCSK9. Our group has identified at least 7 or 8 mutations, including some based on studies in South Asia, where they actually confer protection, and pharmaceutical companies are now trying to mimic those protective mutations with a therapy. And so one example actually is the ApoC3 mutation, where a family in Pakistan, some of them actually have 2 missing copies of this gene. And when they drink a fatty milkshake, in all of us, our fat goes up a lot, more than doubles or triples, and it stays up for many, the fat in our circulation stays up for many hours. But if you have the missing copies of this gene, ApoC3, you actually are able to very rapidly clear this cholesterol from the circulation. And that leads to very much lower risk for heart disease over time. And so now multiple companies are now developing this as a therapeutic option. Rajiv asked, can we use the same polygenic score to predict events in a secondary prevention population? So this is, when we're talking about secondary prevention, we're saying somebody already had a heart attack. Can we actually predict the risk of having another heart attack? And what we see is that it definitely works, but we do see that the risk estimate is somewhat reduced, and that's pretty consistent, even if you look at risk factors like diabetes in someone who already had a heart attack. They already had the event, so genetics, which is present from the time you're born, is somewhat less impactful, but there is a significant gradient in risk. Even the risk is still greater than what you see for LDL cholesterol or blood pressure, for example. So we've shown in a number of studies that this score does work reasonably well, even in someone who already had a heart attack, at finding the people most likely to have a second heart attack. Sonal asks, can we use a similar approach for cancer? And definitely, and I didn't have time to show this data, but this approach works for every common disease that we struggle with: obesity, diabetes, atrial fibrillation, breast cancer, colon cancer. And so what we can imagine very soon, actually, we're starting with coronary artery disease as a polygenic score this next month, but very easily you can imagine a very low-cost test. You know, the raw data is less than $50 if you're just trying to calculate a polygenic score. And you could do that early in life, and you basically get a polygenic susceptibility report, and it quantifies your risk, for example, for 10 important diseases. When should you get it? How old should you be when you get a mammogram? So breast cancer screening. It turns out that can be quite important and impactful based on your polygenic score. What about diabetes? Are there something we can do early in life if you are very high risk? And so forth. And so that is definitely where I see the future. Places like MedGenome and other companies in the United States really building out a polygenic susceptibility report. And so Ajit mentions that we find about 25% of people with a heart attack in India have are presenting at less than 45 years. And this is definitely true. And so, you know, in America, it's actually very unusual for us to see a heart attack in a young person, but in India, it happens all the time. And this is a big problem because it happens right when people are in their working years or they have kids and they can't work because they're only 45 or 50 years old. Many even die. And so in India, I think this is a really important opportunity to really find these high-risk genetic individuals and prevent them from having their first event. As Ajit mentioned, the polygenic score, it has its greatest predictive ability. Polygenic score is based on genetics. That's the time you're born in young individuals. And we have some new data just in a publication we're presenting that really speaks to that. But you can imagine if someone's 100 years old, then the genetics you're born with may be somewhat less important. It's all about, did you smoke and what was your cholesterol over 100 years and so forth. So most of the data I showed you is that it's very useful even in middle-aged individuals, but it definitely is true that it would be even more helpful for people at younger ages. Strawback, should all variants be made unidirectional before calculating the polygenic score? Our polygenic scores are available just on our website, and that's really just a semantics question. You can either say you have two variants, let's say one is A, one is C. You can either say A is always the risk variant, and it could be increase or decrease the risk, or just using basic math, you can just say C is the actual variant, and they should all be risk increasing. So I find it sometimes easier to explain if I can say that some variants increase risk, some variants decrease risk, but it's mostly actually just a semantic question. Mathematically, it'll come out the same. Pritesh asks, so in the paper that we presented for South Asians, why was a European linkage disequilibrium reference panel used instead of a South Asian reference panel? This is an outstanding question. And what we've seen is that the reference panel actually should match the population where you did the genome-wide association study. So that study where we looked at 60,000 people with a heart attack, 120,000 controls, that was about 80% European. And we actually tried in our paper the South Asian reference panel, and the score didn't work quite as well. So that's basically the state of the art in 2020 is what we did. But we're very confident that if we work with MedGenome or other partners in India, that we can make an even better polygenic score if we have more South Asian data. We've showed that already in some preliminary data, and that's something we're working on very actively. And so, can we get a polygenic score from whole exome data? And here the answer is no. So the whole exome sequencing only looks at the 1 or 2% of the genome that's the coding, protein coding. But the polygenic score, about 95% or 98% of the variants included are actually in the non-coding space. So how would you calculate the polygenic score? Well, you need either whole genome sequencing, which is a little bit more expensive, or you can actually use a genotyping array, which is actually quite cheap, about $50 US, or you can do something we call low coverage or low pass whole genome sequencing. So there are a few different technologies for how you might be able to calculate the polygenic score. All of them are typically about $50, but you cannot, unfortunately, use, if you only have whole exome data, you unfortunately cannot calculate the polygenic score. Rajiv asked, are there hypotheses? So why is healthy lifestyle actually associated with reduced risk? And here, what we have shown is that there are two things that can drive your risk: genetics and environment for any disease. And what we've shown is actually, they're actually pretty independent. So in our study, we found that it didn't matter what your genetic risk was. Regardless, a healthy lifestyle was associated with a 50% lower risk. So you could cut your risk in half. If you had a very low genetic risk, you cut it in half to something even lower. If you had a very high genetic risk, you cut it in half and only got to the population average. So this is what's really nice for our patients. We say DNA is not destiny. So even if you have a high polygenic score or a monogenic mutation, you can actually dramatically reduce your risk if you follow a healthy lifestyle. And so that's been helpful just in terms of how we counsel patients. Folks, somebody from Halogen Health actually says, in clinical practice, are you sequencing patients or genotyping them and imputing the variants? So at least the test Color is offering soon is actually, what they do is they do very high coverage sequencing. So they focus very carefully on the monogenic mutations, those genes like familial hypercholesterolemia. And the remainder, they do low coverage whole genome and then impute the remaining 6.6 million variants. And there's a paper in Genome Medicine that was in one of the slides that outlines that approach and shows that you can calculate the polygenic score very accurately from that, from using that technology. So let me stop there because I know we're getting close to the end of the hour. And see if I can either take a couple more questions if there's time, or maybe the moderators want to interrupt and offer closing words or questions.
Yeah, we received a couple of questions in the registration process. I'd probably address that to you, a couple of them. You mentioned about applicability in cancer and diabetes. There were some questions on its applicability in infectious diseases such as TB and also nephrology. Any thoughts on that?
So for infectious diseases, it's a little bit more complicated because your genetics, the biggest determinant of whether or not you get tuberculosis is whether or not you get exposed to tuberculosis, and that goes into your lungs. And so there haven't been as many really good studies to show that your genetics plays a very important role in terms of whether or not you get tuberculosis. But there are some studies being done there, and I think that they may end up developing a predictor, but at the moment the science is not there yet for infectious diseases. And even for coronavirus, with the pandemic, we've seen that some people based on their genetics are more likely than others to develop very severe disease. But ultimately, the chance of you getting infected is mostly determined by whether or not you inhale the virus and it goes into your lungs. So at the moment, it's not, I don't think, ready for prime time and ready for clinical use, but it's possible. And I know there are many groups around the world that are working hard on that.
Okay. So next question is, how should a tool like polygenic risk score be deployed? Is it via consumer testing, or should the healthcare systems of various countries and states be involved? And which route would you recommend, and what are the ethical considerations of this technique?
Yeah, I think it really depends on the specific environment. I think in the short term in the United States, I think it's going to likely be a physician ordered test where each physician may decide it's the right test for their patients. But I think in other countries like the United Kingdom, they're studying, 5 million patients, and they're going to recruit them and return all of their polygenic scores at a governmental level, just because they also see the value from the public health standpoint. And I think in India, I've never practiced medicine there, but in India, there's a lot of emphasis on direct-to-consumer testing. And there are many people who just want to know what their inherited risk, via executive health checks or others, what is their inherited risk for heart disease. And in India, many families have just been devastated by coronary disease. Many uncles, parents have died maybe at the age of 50 or less. And so for those people, I think a direct-to-consumer test is very appropriate and will be very useful. And what really is, from an ethical standpoint, what really is very important is that you have a report that actually explains what the score actually means. So a 95th percentile score does not mean you have a 95% chance of getting the disease. It means that your score is higher than 95% of the population. And that is something, that can be very different. And secondly, you need to have physicians. If you take this report in right now to physicians, they might not know what it means or what to do with it. So there needs to be effort to educate physicians via webinars like this, and also finding physicians who are ready to adopt this technology and really give patients a place to turn to once they get a direct-to-consumer test.
Joseph, Ram here.
Yeah,
I think we should get some suggestions and tips, and also some details from Dr. Chopra and Dr. Gupta, considering their clinical experience and expertise, especially in countries like India. What do they think, how things are progressing in the country, and what do we need to do in future?
Yes, definitely. I was just coming to that next. So we have one final question. This is just a general question. What is the possible reason for increased risk of cardiovascular disease in the South Asian population? Any thoughts on that?
Yeah, we don't know. We're studying that very closely. It seems like there's an increased, some of the drivers of increased risk are lipoprotein a, which is a cousin of bad cholesterol that's much higher in South Asians versus Europeans. We also showed that diabetes is actually a bigger risk factor for South Asians than European population individuals. And actually many South Asians develop diabetes even when they're not obese. They have normal weights. And then the last is actually, even for any given weight, South Asians, as many of you know, actually have central adiposity. So the weight tends to cluster around their belly as opposed to their legs. And so we think that's another important driver of the increased risk that's seen in South Asian individuals.
So any other questions on the Q&A window you'd like to pick up, or shall we?
No, I think I'd be very happy to hear what Dr. Gupta and Chopra have to say.
Yeah. So yeah, I'd like to request Dr. Chopra and Dr. Gupta to give their concluding remarks and any questions if they had.
Okay, Dr. Amit, I think I really express my gratitude and thanks to you for your most brilliant and outstanding presentation. And I'm very happy to learn that you started a preventive genome clinic. And I know in my heart it will go globally because it's a huge potential. But there are just one or two important clarifications I need from you. What is the significant variability in this polygenic score from time to time in the same individual, or in the individuals who have some risk factors like their vulnerable plaque, or their vulnerable age, vulnerable patient, vulnerable hemodynamics, and vulnerable hematology, and vulnerable environment, as you just mentioned. I'm sure are these the factors which governs, controls, or mitigate this kind of score, or it doesn't make a difference? Second point, you mentioned about statins and PCSK9 inhibitors role. I think the effect of these drugs, is it constant, or that is also variable from time to time? We like to have this one. Is there any correlation between the reduction of score and the angiographic variables? Any data to correlate the three, like for example, calcium score by CT angio, or a coronary score, some variable, so that we know, yeah, this really works, seeing the cost and how frequently should it be done in the patient?
Thank you, Dr. Chopra. So the one of the genetic testing only needs to be done once. And the reason for that is genetics is actually fixed at the time of birth. So you can do the polygenic score at any point in life when you first see the patient, and you never need to do it again. That's what's really nice about genetics. But whether or not you develop disease, so for any given disease, whether or not you have a heart attack is determined by the interaction of your genetics, which you were born with, and all the environmental factors you mentioned. So do you smoke? That can, especially if you have a high genetic risk, and then you start smoking, that's really going to tip you over into having a heart attack very early in life. Do you develop diabetes? Do you have a healthy lifestyle? Do you have unfavorable hemodynamics, like you mentioned? So it's the genetics is fixed at birth. All these other environmental factors can unmask that genetic predisposition, especially if you were born with high risk. Now, the other question relates to angiography, and what we've seen is that if you have high genetic risk, you tend to have more severe you have higher risk of coronary disease, but even among those with coronary disease, you tend to have more coronary disease. So you have more vessels affected, maybe 3 instead of 2, and so forth. So there's definitely a correlation between the score and the severity of your coronary disease. In terms of medications, the earlier the better. So if you start a statin early in life, we've seen that if you start it before you have your heart disease and you have a high polygenic score, you develop a much greater benefit than if you develop after your event. And this is really the value of polygenic score, finding these high-risk individuals before they develop disease, and then being able to use something like a statin very early before they develop it, where it has the most impact to decrease that risk.
Amit, I think, can you hear me, Amit?
Yes.
Yeah, Amit, I think Inas was here. He did a study in Singapore. He lives in US. And he mentioned in Indians, especially, we should start statins as early as age 13. What are your comments on this? 1-3.
If the goal is to reduce risk of heart attack in the population, there's no question that would be very effective. Earlier, the better. But in my own clinical practice, I think a 13-year-old, they may not have the ability to kind of really think through whether or not they want to take a pill every day for the rest of your life. So that's really a an ethical and interesting question. Scientifically, definitely 100%. If you start early, you will dramatically lower risk. There's no question about that.
Thank you, Amit. Thank you very much.
Dr. Gupta, any comments and final thoughts, sir?
Just to unmute.
Yeah, Doctor. Yeah.
Yeah, I've unmuted. Excellent presentation, Amit, as far as the India and South Asian people are concerned. We are the loggerhead of deciding at what age we should treat the subset who have got a high polygenic scores, as you said. So my question is very simple. How early we can do this test to our population at large, not in a specific population, and whom you should recommend that it should be done as far as the clinical perspective is concerned. Look, many people are suffering at the age of 40, 50, and we have seen many people of 18 to 20 years presenting with acute coronary syndromes. And despite many of them did not have all these kind of risk factors, what you said, at least 4 of them. So what is your suggestion for our own country? That's what my question is.
I think the earlier the better. And so what we know is that the earlier people are identified, if you identify someone when they're 20, that gives them about a 2-decade head start. So they were going to have a heart attack at age 40, but you find out they're high risk for 20, you start a statin, you make sure they're not smoking, you help them with their lifestyle. Instead of having a heart attack at 40, maybe you put it off until they're 80. When they're finished working, their kids are grown and so forth. And so if the test, the test that we're launching this year, I think the people who are most likely to get it would be, maybe I have already had a heart attack, but I want to understand why it happened to me. Did genetics play a role? Maybe I have a strong family history and many people in my family have suffered, so I want to quantify my risk there. And maybe I'm just want to be very proactive about my health. Those are the people who probably would be the first in line to get the test. But I think, moving forward, I think it's really any patient. So heart attack is the leading cause of death across the world, in India, everywhere else. So there's really not anybody who's at very low risk. Everyone's at relatively high risk. And especially in India, where the risk is double, like I showed you, that white people. And so the earlier the better. The earlier you can find these very high risk individuals and help them, the better. But I think some of the earliest people would be people who maybe already have a very strong family history, or you're otherwise concerned about the patient.
That's what exactly I was thinking. Like, if you recommend at the age of 20 to asymptomatic person, maybe many people will not be able to absorb it. And especially if we recommend to a people who are suffering from a young age, like 40 years plus, and we recommend to their sibling, recommend to their relatives or first degree relatives, that could be the best idea we could ever do in this population. What's your comment about all this?
I think you're right. I mean, I think if someone is, 20 years old, they're going to college and they're not focused on their coronary disease, they may not be ready to take action. And so, I think it does need to have a patient who's ready to understand and take account the results. And so at the moment, I think most people may not be when they're very young, but I think the more evidence that we have, just think, you can put someone in 200 dots. If they're in the best dot out of 200, their risk of heart disease is 4%. If they're in the highest dot, the risk is 80%. So when you think about it like that, every patient, I think, may want to know. But it will take some work from MedGenome, from other folks, from our group, to build more evidence and help people understand using these polygenic education tools, actually, to be able to figure out how to understand the test.
Thank you very much, Amit. Thanks a lot.
And actually, before we leave, I'm putting in the chat, which some of you have access to. You should also have access to, just a explainer. So this is something we build that you can follow the link in the chat, and it says, okay, well, what is a polygenic score? And it really walks people through what it is. And so this is just one example of the type of educational tool we think will be quite important.
I hope our audience has made note of the website and has clicked on the link. So I think we can conclude here. So on behalf of MedGenome, I'd like to thank Dr. Amit Khera for taking time off pretty early, actually, in the morning, and giving us this very insightful talk. And I'd also like to thank the eminent cardiologists on our panel, Dr. Chopra and Dr. Gupta, for taking time off from their own busy schedules and presiding over this webinar. Also, a special thanks to Dr. Muralidhar Kanchi and Dr. Poonam Malhotra for facilitating this webinar. And if you have any more questions or comments, please don't hesitate to write into us at diagnostics@medgenome.com or give us a call on our toll-free number. If you want more information on polygenic risk score, you can visit our website, www.medgenome.com, and look for polygenic risk score CAT. And so that's about it. We have a short survey at the end of the webinar. I request the audience to take a few seconds to answer those questions. So once again, thank you very much to our speakers, our panelists, and also to the wonderful audience who signed in for this webinar. And until next time, goodbye and stay safe. Thank you.
Thank you.